Hello, everyone.
Hello, everyone.
Welcome to the World Federation of Society of Anesthesiologists, a webinar on cardiopulmonary resuscitation, improving outcomes. I'm Sheila Myatra, Professor of Intensive Care, working at the Tata Memorial Hospital in Mumbai, India. I'm also the chair of the Intensive and Critical Care Medicine Committee of the WFSA. Today, we have an excellent lineup of speakers and some great talks and great discussion that will follow. And I want to let you know that this is the first of the webinars that is led by the Intensive and Critical Care Medicine Committee of the WFSA, and it's part of our bi-monthly webinars that has been planned going forward. Before we start with the outline of the talks, I'd first like to introduce my two co-moderators. And the first one is Professor Seda Banu Akinci, and she is from Ankara, Turkey, from Hacettepe University. She's a professor of critical care medicine from the Department of Anesthesiology, and she's also an active member of the ICCM committee of WFSA. And we also have with us here Professor Suneerat Kongsayreepong, who is from the Siriraj Hospital in Bangkok in Thailand. She is from the Faculty of Medicine and from the Department of Anesthesiology, and she's also an active member of the Intensive and Critical Care Medicine Committee of the WFSA. So without any delay, I'm going to hand over to our moderator, Professor Seda Banu, to take the webinar forward. Over to you, Professor Seda Banu.
Thank you very much, Sheila. We are all very much excited about our self-esteemed three highly expert speakers. The first one is from Brazil. Associate Professor Naomi Kondo Nakagawa is a physiotherapist from the Faculty of Medicine, University of Sao Paulo. She is holding an MBA in hospital administration and a PhD in sciences. She has many publications and actively involved in coordinating Kids Saves Lives Brazil, which is, she's going to talk about Kids Saves Lives. Thank you very much for this talk. The floor is yours.
Thank you very much for the WFSA for inviting me to participate in this roundtable. So I have no conflict of interest to then being the Brazilian coordinator of Kids Save Lives. Sudden cardiac arrest is an event that has a prevalence of approximately 700,000 per year in Europe and the US, with a high mortality rate in out-of-hospital environments. The global incidence of sudden cardiac arrest largely varies from 20 to 170 per 100,000 person years, depending on bystander time response, previous CPR training, availability and adequate use of AED, emergency medical service system, healthcare infrastructure, public awareness campaigns. Risk factors that significantly influence the likelihood of cardiac arrest are age, sex, family history, cardiovascular morbidities, lifestyle, and the recent reviews highlight the association of these factors with high out-of-hospital cardiac arrest incidence, with a special focus on prevention and the early intervention strategies implementation. More than 50% of sudden cardiac arrest occurs in out-of-hospital environments. The survival rates in these cases have been improving but remain low overall, and the ranges between 2% without immediate bystander response and 27% in some countries where there are strong pre-hospital emergency services and also advanced life support. Bystander CPR prior to emergency responder arrival significantly increases the likelihood of a return of spontaneous circulation and improves the chances of survival with favorable neurological outcomes. A long-term Danish study showed that survival rates for cardiac arrest victims tripled over 10 years, largely due to increased CPR education. It has been 10 years since the Kids Save Lives project was first launched by Federico Semeraro and Professor Böttiger in Europe. These two key figures in bringing CPR education for children have highlighted the importance of early teaching CPR in schools as vital strategies for increasing survival from out-of-hospital cardiac arrest. Both of them have significantly contributed to the global implementation of the program endorsed by the European Resuscitation Council, by the World Health Organization, and by the International Liaison Committee on Resuscitation. Since its foundation, Kids Save Lives expanded globally, adopted in more than 50 countries by a multidisciplinary team that made great effort to enroll several organizations and institutions to implement CPR education for school children. Countries that have incorporated this program into their educational system have reported marked results, increasing CPR knowledge, skills, and the willingness to act during emergencies. In some countries, Kids Save Lives and politicians have successfully implemented mandatory CPR health education for school children, few of them since primary school. The World Health Organization recommends CPR training for children aged equal or more than 12 years old. Recently, EUCOR recommends children with age above 4 years old, mostly because they are very motivated and have the interest and the willingness to help since a young age. Considering the chain of survival, young children can detect a non-responsive person with abnormal breathing and make an emergency call, give some information. However, only older children are able to perform effective chest compressions, mouth-to-mouth ventilation, and use correctly AED. Hopefully, the inability to adequately perform CPR does not change the willingness to learn CPR. BLS training should be integrated in school curricula to save more lives with good clinical outcomes. Who should teach? School teachers as BLS instructors. The appropriate children age should be any from 4 years old, independently of any age. The group size, 3 to 5 children or 5 to 10 adults per instructor. The first session duration should be more than 2 hours, including theoretical and practical BLS. The assessments of the performances should be performed by a checklist or a real-time software. To improve retrieval, one refresher course with 30 to 60 minutes yearly. To improve engagement, inclusion of school children in our awareness public campaigns, and technology should be used ideally in combination with face-to-face training, virtual reality, gamification, real-time feedback, and so on. Let's raise some aspects on the CPR education in low resource settings, considering feasibility and sustainability. Who should teach? Students, teachers, community leaders, and so on. Group size, all students of school classes or big groups of pupils. The training equipment should be the low-cost mannequins and draw AED. Performance assessments should be performed by a checklist. And to engage politicians and society in awareness campaigns to get financial support for education or health education, the government for sure, but also the society and the public or private enterprises. There are some barriers for implementation, such as lack of time in the school curricula, insufficient BLS instructor training, limited resources like human and equipments. However, benefits of BLS training should be emphasized. The implementation of the overall community awareness, increases in willingness to perform bystander CPR, enhancing sense of responsibility, confidence, and an overall community awareness. More lives can be saved with good neurological outcomes and quality of life. Future challenges and opportunities worldwide can be also for Kids Save Lives initiative, like to standardize the assessment methods for BLS performance at schools, to evaluate regularly the local program, to get investments in education and health resources for the success of the life-saving initiatives like Kids Save Lives, to maintain international cooperation and to ensure widespread adoption of BLS training in national education policies. Now, I am going to present our Kids Save Lives Brazil experience. Professor Maria José Carmona first contacted Professor Bernd in 2016 about Kids Save Lives, and in December of 2017, I entered in the project and established an international partnership to develop Kids Save Lives in Brazil, authorized by Dr. Federico Semeraro and Professor Bernd Böttiger. We began to implement BLS in schools and at the University of São Paulo Medical School. We also initiated a project at the State of São Paulo Parliament to improve awareness and BLS training, and with very low budget, we started with the low-cost mannequins handmade by children and teachers. And in 2019, we entered in the World Restart a Heart Initiative, as well as in the American Heart Association as a fellow, and in the European Resuscitation Council as a full member in the Science and Education Committee of Basic Life Support. We started as an optative discipline in graduation of the University of São Paulo, with a collaboration of a multidisciplinary team to cover cardiac arrest, stroke, choking, acute myocardial infarction, and drowning. Simultaneously, we invited leaders, professors from other universities and professional organizations. We also get international support for our Kids Save Lives Brazil with leaders in academic areas, including Professor Bernd Böttiger, Federico Semeraro, Andrew Locke, Robert Grave, and Walter Renier from the European Resuscitation Council and the World Restart a Heart Group. We have some contribution to the society, like materials, one book, one folder, 8 comic books, one institutional Instagram, one institutional site with several contents, like interviews, saving reports, classes, 15 instructive YouTube videos, and 4 memory cards for choking and CPR in adults and babies. We also have a scientific contribution to the literature, 4 letters to the editor, 2 narrative reviews, and 4 original full papers up to now. But the most important thing is the recognition from the society. We have also received 2 awards for best work and honor to merit in 2 congresses, and more recently, the recognition of the State of São Paulo Parliament, an international recognition from the American Heart Association under the great coordination of Professor Bernd Böttiger, for the multidisciplinary team work in 2019, and next month for the Kids Save Lives initiative. We perform more than 14,000 BLS face-to-face training for children, adolescents, and adults. Almost 1,000 of remote training during COVID-19 pandemic, and also trained 185 young children with the CPR song. From the 14,000 people trained face-to-face, we have some reports of saving lives. Bianca saved her grandfather. Benedita saved her granddaughter. Victoria saved her son. Janine saved her father. Julia saved her mother. Natalia saved her son. And also Marcia saved a student, Rafaela, at the school. So I have to emphasize here the great importance of continued involvement of a multidisciplinary team working with ethics, commitment, and leadership to expand the Kids Save Lives project, trying to make CPR part of the school curriculum in all countries of the world to save more lives with high quality of life. So I would like to thank you very much for this opportunity and for your attention. Thank you.
Thank you so much, Naomi. Thank you. That was a fantastic presentation. Over to you, Suneerat.
Yeah, it's my great honor to introduce Professor Böttiger, who is a well expert in anesthesiology, critical care, and cardiopulmonary resuscitation. He did a lot of research work and are deeply involved in the European Resuscitation Council. Please welcome Professor Böttiger.
So thank you very much. It's a great pleasure for me to give you an update on TTM and post-resuscitation care. Please see here my conflicts of interest. And what is most important? Most important is early start of cardiopulmonary resuscitation. The only thing you need to use is 2 hands to bring the blood flow and oxygen back to the brain. The brain cannot survive without oxygen and is consuming its oxygen very fast, but in the rest of the body, there is enough oxygen for minutes. So pumping blood to the brain is most important for survival of the brain. You have already seen a chain of survival or different chains of survival by Naomi. And this is in my most important chain of survival because it shows based on real data what is really important. And as you can see here, early recognition and call for help and early CPR is much, much, much more important than early defibrillation or post-resuscitation care. Because the brain starts to die after 3 to 5 minutes. And if you miss this time window, it's all over and we cannot do anything to save the brain in the hospital. So post-resuscitation care is only a very small part of the chain of survival. We can do something, but most things must be done by lay people, by school children in the out-of-hospital setting. Let's start with cooling and with hypothermia, which is a topic which has been discussed over the last years very intensively. And I would like to start with a case report. Winter in Cologne some years ago. Alarm, child under ice in ice cold water, 6 years old. The water rescue arrived 25 minutes later and the time in icy water underwater was up to 35 minutes in this lake. The child was then transported to our emergency department during ongoing CPR and arrived more than 1 hour after drowning with ongoing cardiopulmonary resuscitation. Glasgow Coma Scale 3, white pupils, apnoea, this is the temperature, 33 degrees Celsius, and asystole. We did further CPR for 1.5 hours, and we put him on ECMO for 3 days, and we didn't rewarm him to normal temperature thermy, but we rewarmed him to therapeutic hypothermia, which was 34 degrees Celsius. Then we weaned him from ECMO, and 2 days later we extubated the trachea, and the family was with us in the room, and we were all very afraid what will happen. And the child opened his eyes and asked for bread with Nutella. So he survived despite 35 minutes without oxygen in ice cold water in good neurological conditions. So what I would like to say with the early hypothermia, cooled very fast and very early, is effective because, why is that? As you can see here, this is a simplified model of mechanisms following ischemia. This is really very simplified, so don't worry. And the nice thing is that hypothermia is working positively in all these pathways. And one of the trials that showed success with early cooling was the Princess trial, where they cooled already during ongoing cardiopulmonary resuscitation in the out-of-hospital setting. Both groups have been cooled in the hospital, and in one group, cooling already started during ongoing CPR by nasal cooling with perfluorocarbon in the out-of-hospital setting. And as you can see here, complete neurological recovery, cerebral performance categories 1, in the subgroup of patients with ventricular fibrillation, significantly higher in those who have been already cooled in the out-of-hospital setting. I would like to repeat, both groups have been cooled in the in-hospital setting, but in the out-of-hospital group, cooling started immediately, like in the child, I would say. And as you can see here, time to cooling and neurological outcome is important. The earlier the cooling is effective, the higher is the neuroprotective effect of cooling. That is the reason why we are always cooling our patients following cardiac arrest at least for 24 hours and sometimes longer. And we are always starting cooling as early as possible. Then some 3 or 4 years ago, there was a study appearing in the New England Journal, Hypothermia versus Normothermia after out-of-hospital cardiac arrest. And you can see it's a very large study, more than 1,800 patients randomized. But not all patients have been enrolled. As you can see here, bystander performed CPR was 80% in both groups, and shockable rhythm was 75% in both groups. This is at least not our patients. We have 20 or 25% ventricular fibrillation, and we have about 40% of bystander CPR rates. So many patients have been excluded in that study. And most importantly, you can see here the temperature curve, and you can see here hours since randomization. And the temperature in the hypothermia group was reached about 5 to 6 hours following randomization. And if you look into the manuscript, randomization took 2 hours after the arrest. So you have to add these 2 hours. So overall, the temperature in the hypothermia group was reached at 6, 7, or 8 hours after the arrest, which is very much too late. Therefore, there was no difference reported in this New England Journal publication between normothermia and hypothermia, and the overall survival was very good because they had 80% lay resuscitation rate, which is the key to survival in both groups. And ischemia duration extrapolated from the TTM1 study was 1 minute in median because of the high rate of bystander CPR. The duration of downtime without any blood flow was 1 minute, and I would not expect any positive effects of any temperature management following 1 minute of ischemia. And as said, the target temperature was reached more than 7 hours after the arrest. Lay CPR rate 80%, shockable rhythm 75%. This is not our patients, and that's not the therapeutic window where hypothermia is working. I have to add that no animal studies show any effect with application of hypothermia more than 7 hours after the arrest. So the question was, are these our patients, and we analyzed that, and we have published that in the European Journal of Anesthesiology. And as you can see here, TTM1 and TTM2, with bystander CPR rates of 70 to 80%, there was no additional benefit per 1,000 patients treated with hypothermia. But if you have lower rates of lay resuscitation, there is a benefit. And these are our patients. In Germany, we have lay resuscitation rates of 40%, and in most areas of the world, it is even lower. And there is an effect of targeted temperature management on depending on the severity of encephalopathy, which is very logical. So if you have only very mild encephalopathy, there is no effect of temperature management. And the same applies if you have very severe encephalopathy, no effect of temperature management. But in the intermediate group, moderate encephalopathy, there is a huge and significant effect of mild hypothermia. And the TTM1 and TTM2 trial was primarily focusing on patients with mild encephalopathy. So if you would ask a cancer patient, if you tell him there is a therapy that has no side effects, we don't know whether it is working in you because we don't know the severity of your insult, but in moderate insults, it is working. What would a cancer patient want? She or he would definitely say, please give me hypothermia. That's the reason why we take 32 through 34 degrees Celsius for at least 24 hours in adults as soon as possible. And this is also supported by a most recent Cochrane review published last year on hypothermia and neuroprotection in adults after cardiac arrest. Neurological outcome, significant improvement. It is not depending on the location of cardiac arrest. Out of hospital cardiac arrest, significant improvement. In hospital cardiac arrest, significant improvement. And most interestingly, if you have bystander cardiopulmonary resuscitation rates, as in the TTM1 and TTM2 trial of more than 70%, there is no effect because there is no brain damage if you have high lay resuscitation rates. But if you have lower lay resuscitation rates, there is an effect of hypothermia. So we are cooling our patients for at least 24 hours until we reach lay resuscitation rates above 70 or 80% in Germany, and we are far away from that. And we are focusing on very early cooling. We start already in the out-of-hospital setting or in the emergency department, as in our 6-year-old patients. And studies on that, clinical studies, are also on the way. We recently published a statement from the European Society of Emergency Medicine and the European Society of Anesthesiologists supporting that view. What are the top messages on post-resuscitation care in the most recent guidelines of the European Resuscitation Council? Oxygen, not too much and not too less. PCI, always as soon as possible in ST segment elevation infarction. Temperature management for at least 24 hours and avoid fever for at least 3 days. Prognostication, please do it not earlier than 72 hours after the arrest, because otherwise you will miss patients that can survive in good conditions. And rehabilitation is also a very important issue. Again, I would like to repeat, prognostication not within the first 3 days, because then you can have wrong signals. Out of hospital cardiac arrest and survival. Is it important to go in a big hospital or in a cardiac resuscitation center? We have signals from systematic reviews and meta-analysis that transporting patient to a center is associated with a twofold increase in survival. That was the reason why we have established all over the country in Germany, and we are the first country who have this cardiac arrest centers. We have more than 140 certified centers right now in Germany. So we are on a good way in Germany, but we are the leading country with the establishment of cardiac arrest centers in Europe. We are in progress, and this can also be a blueprint for the world. And has this establishment of cardiac arrest centers an effect on neurological outcome and eCPR? Yes, it has. We have recently published that this year in Resuscitation. as you can see here, favorable neurological outcome has been significantly increased with the establishment of cardiac arrest centers in Germany. Coronary angiography and percutaneous coronary intervention in cardiac arrest patients without return of spontaneous circulation. Sometimes you have patients in the out-of-hospital setting that do not gain return of spontaneous circulation, and you need to transport them under ongoing cardiopulmonary resuscitation to the next hospital. In this study of nearly 700 out-of-hospital cardiac arrest patients, one-fourth did not have return of spontaneous circulation in the out-of-hospital setting. These patients had higher rates of coronary occlusion as the underlying cause of deterioration, which is the fact in 60 or 70% of all cardiac arrest patients. And interestingly, 30-day survival was 24% in patients that were transported to the hospital, to the PCI lab with ongoing CPR, and 70% in patients with return of spontaneous circulation in the out-of-hospital setting. So it is worth to transport patients from the out-of-hospital setting into the cath lab with ongoing cardiopulmonary resuscitation. What are the oxygen targets in comatose survivors following cardiac arrest? Most recently published 800 patients in the New England Journal. They compared around 70 millimeters of mercury for oxygen to around 100 millimeters of mercury oxygen, and there was no difference with the incidence of death or any severe other outcomes, as you can see here in the Kaplan-Meier curves. So you do not need higher levels of oxygen, and please avoid very high levels of oxygen because they might be detrimental. What about blood pressure targets in comatose survivors following out-of-hospital cardiac arrest in the post-CPR setting? Again, a publication in the New England Journal, they compared 77 millimeters of mercury versus 63 millimeters of mercury. And again, there was no difference between the two groups. So you do not need to use too high levels of catecholamines. A mean arterial blood pressure of 63 or 65 is enough. So what are my conclusions and what is the message with regard to TTM, targeted temperature management, and post-resuscitation care 2024? We are cooling our adult and also our younger children and newborns on a temperature of 32 through 34 degrees Celsius for at least 24 hours. In newborns, we are using 72 hours. If good neurological outcome is not for sure. So in any doubt, cool them down because it is without any severe and compromising side effects. We are doing PCI in all ST segment elevation infarctions, and in our country, it's best to transport patients to cardiac arrest centers which have been established all over the country in the meantime. Prognostication, don't do it within the first 3 days because you might be wrong. Do it and execute it after 3 days. And please establish normoxia, normal blood pressure, and normocapnia in all our post-cardiac arrest patients during post-resuscitation care. And with this, I would like to thank you very much. And please do not forget the effects of hypothermia. Always think about Nutella. Thank you very much.
Thank you so much, Prof. Böttiger. That was a really informative presentation. I'm sure there are lots of questions from the viewers, and please keep the questions coming in the Q&A section, and we'll try to address as many as we can at the end of all the 3 presentations. It is my great pleasure to introduce Professor Rakesh Garg. He is a professor of onco-anesthesia and palliative medicine from the B.R. Ambedkar Institute Cancer Research Hospital, which is part of the All India Institute of Medical Sciences in New Delhi in India. He's also the editor of the Indian Journal of Anesthesiology, and he's very actively involved in teaching and training in resuscitation, and being an integral and key part of forming the Indian Resuscitation Council Federation. And he's going to talk about the role of the national resuscitation councils and their role in maintaining CPR standards. And he's going to use the journey of CPR in India as a case study. So really looking forward to your presentation. Over to you, Rakesh.
Thank you, Dr. Sheila Myatra, for the introduction and taking it forward. And thank you to the leadership of WFSA, who has taken this nice initiative of various aspects of CPR. So after two nice interactive, nice sessions of the information, let me take you through some of the important aspects of CPR when we talk about the Indian population. So when we talk about the Indian continent, maybe 10 years back, when we're looking for our guidelines, the various sources, the data and the registry has mentioned that not many people are trained for cardiopulmonary resuscitation in India. This was a generic survey which was done across India, and people were able to look for the status of CPR. And this was repeated a couple of years later also. There was a slight change, but not much change has happened. So this prompted us to do something, because we have now understood very clearly that the resuscitation is an important aspect. And hence we have to do something so that people are taken care of the resuscitation. It was a real challenge, and various reports were coming from India that such a big population, 1.4 billion, and we need to train them everybody. We need a big chunk of trainers and the centers that can be that are required to train people for the resuscitation across India. And this challenge is specifically over and above when we have most of the cardiac arrest, more than 70% of people have cardiac arrest at home. And when they reach hospital, almost 90% has already succumbed to the death, and they are not having return of spontaneous circulation. And the cardiac arrest rate is almost 4280 per 1 lakh, which is a big number. And this requires that we have to act immediately, because evidence has clearly mentioned that any delay by a minute will decrease the chances of resuscitation by almost 7 to 10%. And looking for this aspect, the like-minded person, the enthusiast person from India, to begin with, it was the leadership of Indian Society of Anesthesiologists, who get together and try to formulate the guideline. Though this has been done in earlier days also by similarly enthusiastic group of people, but for some reason that could not be picked up onto a big platform. But this initial meeting of the various representatives, primarily from the Indian Society of Anesthesiology taking a lead, they came together and thought of that why not to create a guideline which is having our own data into it and our own requirement into it. And this was also a concern when we talk about the low survival rates, because one of the reasons was that when the guidelines from other continent or other regions are coming up, they have many differences with regards to the infrastructural aspect, geographical aspect, teaching training aspects, and probably that will be the reason that the applicability may not be good. And various international guidelines, though they are very well framed, very well evidence-based, but may not be applicable because of many reasons with regards to the infrastructure, geographical, demographical variations, and obviously some aspect of the financial concerns also. And this is what the Indian Resuscitation Council, under the ambit of Indian Society of Anesthesiologists, for the first time came up with guideline. And the reason is, when we're talking about the general population, we want that people should do resuscitation at the site. And it was a lay person who should do it. And that's why we came up dedicated guidelines for these people, which was labeled as compression only life support, which emphasize on the layperson training. And that's why these guidelines becomes a buzzword nowadays, and many lakhs of people are being trained for it. Simultaneously, we were having basic guidelines and the comprehensive guidelines, and we label them comprehensive because we want that the people should understand that one algorithm should be folded into a healthcare center, and that's why we labeled it as comprehensive rather than the advanced one, so that there's no confusion between basic and advanced one. And we came up with the code links, which were different for 3 groups of guidelines: the layperson CPR, the calls, the basic cardiopulmonary life support, BCLS, and comprehensive cardiopulmonary life support, which entails about the basic principles for teaching and training purpose. And we also brought about the algorithm, and just to differentiate between them, we made them color-coded so that when there is a transition from a basic or a layperson to a healthcare sector, they know very well that which guidelines have to be applicability. They were a little descriptive so that people can understand them better and can follow them up better. When we talk about its popularity, now once the guidelines are framed, it has to taken to the masses. And when it's taken to the masses, we have to rope in the dignitaries who are influencers. Indian Society of Anesthesiology was definitely the influencer here, but we have taken together all like-minded persons from the bureaucracy, from the government organization, from the corporate sector, so that its applicability, the acceptability, and dissemination becomes better. And these guidelines were released at multiple platforms in different areas. Now, at this juncture, though it was an initiative of the Anesthesiology Society, the Indian Society of Anesthesiologists, but then we realized that the resuscitation is required for all healthcare workers. They should learn it. They should have active participation into it. And that is what we are moving towards, the federation. I think that's the key word, rather than having few organizations or few professional bodies into it. Why not to include all the professional bodies who are involved into providing clinical care? And that's why this Indian Resuscitation Council was subsequently having many other professional bodies a part of it, and it was labeled as Indian Resuscitation Council Federation. And that has really given a boost that the different professional bodies, when they come up, it really has a good impact for increasing in the teaching and training activities all across India. And we have more than 150 centers now, courses going every week at these centers, not only for the healthcare workers, but paramedics, and also for the layperson, which is a huge number now, which is being done for almost every nook and corner of the country. And this impact of the guidelines formulated by IRCF has really given a lot of boost in teaching, training activities, learning activities, and it has probably improving upon the outcome also at various aspects. And we can see that these are the few snapshots of the various news I've just tried to capture for the last around 2 weeks or so. Almost every day, impactful message news is coming from the national media in various platforms that people, the medical, the paramedicals are doing it, and the peoples are being saved. And there have been a lot of invitations from various organizations, non-medical organizations like journalist group, the bureaucrats group, other organizations also, that they want to do the workshops in addition to the healthcare worker. And not only this, a lot of success stories are coming up into the media through the various videos which was captured by the media news personals, the public also, and they are being repeatedly reported, which itself shows that when a massive training along with sensitization and awareness is created, probably it would definitely have an impact on the patient's outcome, on the delivery of the resuscitation, impactful delivery of the resuscitation to the public. Now, once we have guidelines, we want that this guidelines should be more robust. And many people across the globe has been working for the resuscitation science. And the International Liaison Committee on Resuscitation is actually a group of highly qualified researchers and academicians who has been creating resuscitation science and putting forth one. And IRCF joined the ILCOR sometime back with a common mission that we want to train maximum number of people across India, across this side of the world, so that we can improve the outcome of our patients also. And with this common mission in our mind, with the IRCF collaborating with ILCOR at various level, we have started training them. And not only this has an impact, but this also had an impact on various resuscitation programs being launched by various medical education training program like National Board of Education and Medical Sciences, Ministry of Health and Family Welfare, which is the main statutory body which is involved in controlling the teaching and training activities in India. And not only this, when we talk about a World Restart a Heart Day, landmark event started by the ILCOR, we are again taking it forward, creating more awareness more sensitization, and this is being impacted into various publications which are coming to the ILCA, in which Indian Resuscitation Council is putting a lot of effort to create more training, to more awareness, more sensitization, and year after year, we have good number of participation for creating more impactful training into a large number and still maintaining the quality. And that is what IRCF has been creating more awareness in the form of release of postal envelopes, postal stamps. I think these things has become important. And this has also become important because when a regional organization wants to start something, it needs to have a good, robust support from the other part of the countries also. And that's why when the Indian Resuscitation Council joined ILCOR as a full member in 23, it has really given a good, robust, good strength to the Indian Resuscitation Council Federation, because not only the ILCOR leadership is supporting IRCF for creating more robust guidelines, guiding us for its reach into the various nooks and corners of the country. And simultaneously, there are many other aspects like research, like registries, which again becomes good. So this membership of IRCF from India has really given a boost, really given strength to the conduct of teaching and training with regards to the resuscitation. And I'm sure in near future, this type of collaboration and support from other councils also across the world will collaborate. And it's a world of collaboration now. This collaboration will help us to strengthen our country, to strengthen our people, to strengthen our healthcare system, to provide effective, impactful resuscitation. And why we are saying so and what's new we are doing it, because we had limitations, we have understood there are many things. Let me give you just one example for that. Why do we need guidelines for our country? When we say the hand position for chest compression, and there are many examples for it, but due to paucity of time, I'll just put one. When we say the chest compression rate, there are many sites which has been put for the chest compression, interlateral line, lower sternal areas, lower third of it. And there have been many researches which has come up that because of the demographic variations across various continents, because the various population have different demographic, different physics. And the studies had mentioned that probably like in this study, which is coming from probably this area, that the internipple line does not correspond to the left ventricular outflow areas. Probably it leads to more amount of an obstruction. The compression is more over the left ventricular outflow tract actually, and it causes more of an obstruction rather than increasing the output. And same has been very clearly shown in multiple studies of transesophageal echocardiography, CT scans, and MRI. So this example, when we say, is an example, we say that this is the reason we need to have a good guidelines from our country. Similarly, when we saw the resuscitation and the ROC, it depends upon reversible causes. In our country, being a diabetic country, we need to include these factors also. And this becomes important to understand and bring those changes into our guidelines, which we have done successfully. And this type of initiative by the ILCOR again is a good initiative where we are talking of low resource settings. India being a country where we have on one side low resource setting, on other side, we have a tertiary care centers, which are fully equipped in all the facilities. So we cannot have a single guideline, but I think these type of guidelines which are coming from the ILCOR leadership probably will help when we have these type of concepts of chainmail of survival. I think this will be really a boon for people across the world who are involved into resuscitation to bring the changes. And that is really helping us also. Now, moving forward, we had our guidelines, we have created a sensitization, we have created an awareness, people are enthusiastic, outcome is improving definitely, and lot number of people are being trained. What next? We need to have our own data. When we talk about resuscitation science, we need to have our own data, and that's why we needed our research. That's why we needed an area where we can publish also. And that's the initiative when we started the Journal of Resuscitation, which has really given a boost. And I'm sure the various leadership, and especially today, I have a humble request to WFSA also, that why not to put an effort to the countries like us to put more research, more funding into it, so that we can have a data from our own population rather than extrapolating data from the other countries, which may not be suitable, though robust. And this type of publications coming from India, I'm sure that in future we'll have more research and we'll make our guidelines, which is more suitable, more applicable, and probably will increase the outcome based on our own data. And this is what we are looking in the future, having more compositions. Looking forward, now it's a time we need to have more hybrid training, and the Indian Resuscitation Council Federation, because we have to train millions of peoples, we are moving from total physical type of teaching and training program for a hybrid program. I'm very sure that in near future, many of our programs will be hybrid. And we are also looking for the CPR registry program so that we can have data, we have our own requirement, and we will be able to manage our patients based on our data more better. The journey continues. I'm sure in near future will be more robust, coming up more data, more research, and probably will also be able to improve our countrymen by making every citizen a lifesaver. Thank you so much.
Thank you very much, Rakesh, for sharing the journey of CPR in India as a case study. We've had really 3 very informative presentations, and I'm sure there are lots of questions that we're going to take after this. I'd just like to say that the reason we chose this topic, cardiopulmonary resuscitation, improving outcomes for this webinar, was because as you've already heard, it was World Restart the Heart Day. So it was in support of the World Restart the Heart Day that we selected cardiopulmonary resuscitation for our October webinar. And I would also like to congratulate Dr. Chakra Rao, Dr. Rakesh, and the entire team in India for getting the Indian Resuscitation Council Federation as a member of the ILCOR. So since we are a little short of time, we'll go directly to the questions. There are many, many questions that are coming in, and keep your questions coming in. I'll start with you, Naomi. There are many questions for you, but I'll try to take them all together. Now it was, firstly, congratulations for your huge efforts to engage small children and, school children very early in their curriculum, in their school curriculum, in resuscitating and sensitizing them, because they are our future. And, this is amazing. And I really congratulate you for what you've been able to do in Brazil. Now, the questions that people asked, because you mentioned that children right from the age of 4 years were involved in resuscitation. So how, to give effective CPR, and, is it just about sensitizing them for the future, or were they trained to give CPR? Because how effective would it be, the pressure that they're applying when they're a small child? How effective? That is the question. And also these recommendations that they're giving, have they been validated, or is it like, kind of good practice statements that is given by your organization?
The main issue is what are the main objectives due to age range. For this age range, young children, 4 to 6 years old, the main message should be the recognition of emergency situation and call for help. That's the main point. So no responsibilities for the other things, only to get in touch with the primary objectives of the cardiopulmonary resuscitation. So we can perform this kind of CPR issue by doing some drama, songs, and games. There are a lot of things that we can use as strategies. So what is important is that in very early age, some children can call for help. So Professor Bernd Böttiger has a very nice video of one young child that asked for help using the iPhone. So this is the most important. See that there is an emergency situation and call for help.
Yeah, so as I understand, it's more that you train them for early recognition and calling for help. And of course, if you sensitize them going forward in future, they will also be involved in resuscitation. Just one more question. What are the barriers that you faced while trying to implement, CPR training in such young children? I'm sure you must have faced many barriers, and it's quite a challenge to train such young kids. So can you share some?
Young children can be enrolled with like a joy. If you see that there is some point to reach, like as a team group with the teacher, with the parents, and all the family, then they can have some joy and some learning. The most important is to do this once, twice, 3 times, or five times in a week, and then again next semester or next year. This is just to introduce the cardiopulmonary resuscitation.
Yeah, thank you. Seda, you want to ask some questions?
Yes, I'm going to ask to Dr. Böttiger. I'm going to combine a few questions together. People are asking about reperfusion organ injury, prevention of reperfusion organ injury during cardiac arrest. And they're asking if early ECMO is helpful, and others are asking if they don't have ECMO, what should they do for prevention of reperfusion organ injury?
Okay, the best is prophylaxis. So start CPR as early as possible by children or by lay people. Don't wait for the ambulance, because the ambulance is always coming too late in cardiac arrest patients. And that is the most important message that should also go out to the lay persons. We do not have any drug that helps to reduce post-resuscitation reperfusion injury. The only thing we have is cooling, and this must be established as early as possible. We don't have anything else in our hands to help our patients.
What about ECMO, sir?
ECMO is a high resource intervention. We have some studies showing that ECMO can help in some patients, but we are far away from recommending ECMO in all patients. ECMO, if you don't have lay resuscitation, and if the brain is already dead when the ambulance arrives, ECMO does also not help. ECMO may help in cases where you can put them on ECMO and then go for causal treatment of the arrest, for example, into the PCI lab. But as I have shown, you can also do ongoing CPR in a patient and bring her or him to the PCI lab and then open the affected coronary artery. This is also an effective therapy. So ECMO, yes, in selected patients, young patients where acute myocardial infarction is highly probable, or in patients who have very deep hypothermia, you can put them on ECMO like we did it in our child, but only in selected patients, not for everyone.
Thank you. Suneerat, it's your turn.
Yeah, thank you very much, Dr. Böttiger. I also have the question for you. They have a lot of questions about, do you have the age limited for the hypothermia, and what kind of temperature you select? Because you mentioned about 32 to 34, but the recent guideline mentioned about 36.
Yeah.
How do you select the temperature for the patient?
Okay. First question, we don't have any age limitation. So if we resuscitate a patient, we should cool him or her down if we are not sure that we have good neurological outcome without any age limitation. And we are cooling, you cited me correctly, for 32 through 34 degrees Celsius. The recommendation of using 36 degrees Celsius is based on the TTM1 trial, which has been criticized by many people, as I have showed you with the TTM2 trial. They had very high 80% lay resuscitation rates. it took 7 hours until they reached the temperature, and they found no difference between 32 and 36 degrees Celsius, but this is no wonder. So the recommendation on 36 degrees Celsius is based on a trial that, at least in my group of colleagues, is criticized very heavily, and that is the reason why we choose 32 through 34 degrees Celsius, which has no severe side effects. So we are always saying, in doubt, cool the patient down. You will not harm her or him at any time with this.
Thank you.
Thank you.
Yeah, excellent question. I want to ask you, Rakesh, there are lots of questions coming in. And again, congratulations for formulating the guidelines. Now, how would you able to, make this more suitable? I'll ask you 2-3 questions together for local applicability. And also, in the Southeast Asian regions, because our problems and, our challenges are pretty much similar. So can we sort of extend this to the region? There's also a question, there's also someone from Pakistan who's saying that probably we should collaborate. So how can we extend this, and how can we make this more locally applicable? And one more question about, you said if the internipple, location is not correct, then which one is for patients in this region? Are you suggesting another landmark? So if you could take these questions together, thank you.
Absolutely, Dr. Myatra. I think very pertinent question you have asked. Even if you talk about the ICMR, which is the research controlling body from India, has clearly on multiple aspects had mentioned, because of genetic, biological, demographical variations. When we try to extrapolate the guidelines, it may not be suitable for variable reasons. And this is the science behind applicability of any international guidelines to a separate population. On one side, we see that science remains the same, but the selected population which is included into the research is varied. And we have not very good, robust, big research coming from Southeast Asian region of this world. And that is the reason that we need to have more robust data, more robust research coming from this area. Whatever the research is, I just gave one example, and there are many. So when we were formulating guidelines for Indian Resuscitation Council Federation, we have come up this various data. Say, for example, internipple line will not correspond to the left ventricular compression, which is required for this resuscitation. In fact, it will be obstructing the outflow tract. And when we looked for the transesophageal echocardiography and transthoracic echo and CT and MRI imaging, we realized it is just about around 2 fingers above the GF sternum. So which is a little below to the intermammary line. This probably is because of the different physique, different BMI that we have, different thoracic ratio that we have. And that's why we need to have our own guideline into this area. And definitely you asked about the CRO countries, which has almost similar biology, similar physique, similar demography. So I'm very sure that why not these countries come together, being the Indian Resuscitation Council Federation in the forefront, to make a common guideline. Why should we create the things again? And it will be applicable for all those populations, so that what we want is outcome of our population. So we have a combined guidelines. I think I'm very happy it can be taken forward, and we'll be more than happy to collaborate it. And on other side, the ILCOR leadership is supporting us from all aspects. So I think this collaboration, a local collaboration from support from a global population, global leadership, I think this is important. And today's WFSA webinar, again, being a global leadership of the all Federation of Society of Anesthesiologists across the world, and with critical care leadership initiative, I'm sure that when all those stakeholders are coming together, from the givers and from the founders and doers, I think we'll be able to have a robust guideline, and we'll be able to improve the outcome of the victims of cardiac arrest.
Yeah, indeed. We don't want to reinvent the wheel, and we shouldn't work in silos, and we should try to collaborate and help one another. A very good point.
So the next question goes to Naomi again. They're asking if there is a global organization for Kids Save Lives, and is there a way to begin Kids Save Lives in low-income countries, and how to do it, how to implement it?
the umbrella is under Professor Böttiger and Federico Semeraro for Kids Save Lives initiative or projects. I think that you can do what I have done. I use the low-cost mannequins performed by Davi Spielman with some plastic bottles and paper and only it's very few things. So it's very easy to train with this in the schools, and the kids can use that to train their families or friends. So the first thing is to have a small team like you, one coordinator with more 2 or 3 students or guys to do this, and then continue to have some volunteers. It's not expensive. So what you need is persistence, is to be committed with the Kids Save Lives. I mean, to do this at school and what institution that needs these public schools. And so I think it depends on you. And then after that, you can get some financial support. You have some recognition. And if you do research together with education, you can, I think you can grow up very consistently. I think that if you want to get in touch, I can give you all my materials that are free, but they are in Portuguese, and some reports they have a legend in English. The song, CPR song, are also in Spanish, English, and Portuguese, so you can use it whatever you have it produced. So it's free for everyone.
Thank you.
Thank you.
I have more questions for Dr. Böttiger. Yeah, they have a lot of questions. They like Dr. Böttiger to explain a little bit more about target temperature management. Do they have any danger of the cold or cooling the patients? And how should we do?
Yeah, thank you very much for this question. So because of the limited amount of time, I have not shown a recent meta-analysis on thermia. And this meta-analysis was published a year ago, and it shows no effect, no effects on bleeding, no effect of patients down to 32 through 34 is very safe and has more or less no side effects. You have a little bit higher rate of bradycardia in patients who are cooled down, which is physiologically, and you have a little bit higher rate of hypokalemia by ICU patients, and it's easy to manage that. So no side effects. That is the reason why I am saying, in any doubt that you're not sure the logical outcome, cool her or him down. And with regard to cooling, you can start in the out-of-hospital setting. You can start in the in-hospital setting. No cooling technique is better than the other. Intravenous cooling catheters are very invasive, have side effects with regard to bleeding and infection. Surface cooling may be effective and can already start it in the out-of-hospital setting. So no cooling technique is better than any other. You can even start with putting ice from the refrigerator on the patient. That's the way we started, and this is also very effective and very low cost intervention.
Oh, thank you very much. What kind of oxygenation and optimum blood pressure in this patient? Should we go very, very high
No.
blood pressure, or we go with optimum?
Yeah, thank you very much. I have shown the 2 New England Journal publications. So oxygen is enough if you have 75 millimeters of mercury. You do not need 100 millimeters of mercury. It does not harm, but don't go above 200, 300 millimeters of mercury is too much and is maybe associated. We know this from retrospective data. It's maybe associated with enhanced reperfusion injury. So don't do it. And with regard to blood pressure, 65 millimeters of mean arterial blood pressure is enough. You do not need higher in adults. You do not need higher levels of mean arterial blood pressure, because putting them on higher levels, you need more catecholamines and more inotropes, and that's maybe harmful to the heart and to the circulation.
Right.
Thank you very much.
We have more questions for you, Professor Böttiger. So the question is that if someone is resuscitated and takes time, and you have ROSC in a little later, then should you still cool these patients? And why is it only for shockable rhythm? And is there a role for elevating the limbs soon after, during CPR? And why is this not part of any recommendations for resuscitation?
Okay, I start with the last question. We don't have, recommendations are always based on scientific evidence and data. We don't have any scientific evidence that raising legs is improving any resuscitation outcomes. It is improving blood flow to the heart, but we don't have any outcome data, so therefore it's not part of any recommendations.
Perhaps someone should study that.
Pardon?
I said perhaps someone should study it.
Absolutely, anesthesiologists could do a good study on that. And with regard to temperature management,
late ROSC, should you still cool if you have got return of spontaneous circulation late, and why only shockable rhythms?
yes, we are cooling all patients if we are not sure, if we are not 100% sure that they have a good neurological outcome. So if I'm in the OR or in the ICU and I have 1 or 2 minutes of ventricular fibrillation and then return of spontaneous circulation, I would not recommend to cool this patient down, because I'm sure there is no brain damage. But in all the other cases, regardless of the rhythm and regardless of the overall duration of CPR and time to ROSC, we cool them. If you're doing good CPR, anesthesiologists, we all can do good CPR. You can do CPR for 2 or 3 hours, and the brain can survive in good conditions. So time to ROSC is not an issue at all.
Right. In the interest of time, I'm going to ask Seda to just take one final question. There are a lot of questions, and I request the speakers to kindly type the answers to the viewers. So Seda, one question, and then I have an important announcement to make. And then I'm going to end by asking each of the speakers to give one final message to the viewers. One short message to each of our viewers. So over to you, Seda, for the last question.
I'm going to ask Professor Rakesh Garg. Everybody is asking about his recommendation side for chest compression. If not inter-nipple line, then where, they ask.
I think, so depending upon if you're talking about this part of the world, it is 2 fingers above the G sternum, which is the correct side for the chest compression based on various data that we have. So it is radiological and echocardiography data that is looking for. We have to look for the clinical data, and that's why I mentioned Dr. Myatra's questions earlier, that we need to have more research that is this line, is this compression side giving us more good outcome. So we need to have more data, more research on this aspect. But preliminary data says that this landmark, which is suggested by Indian Resuscitation Council Federation, appears to be appropriate for our own population.
Thank you.
Yeah. But of course, it needs to be studied. We need to have
Absolutely.
data that this actually works, right? Of course. So I would just like to end with some important announcements. And I'm very pleased to announce that the Intensive and Critical Care Medicine Committee of the WFSA has initiated 2 competitions and 1 BLS training program for various member societies. Now, first is the period for this is between 10th of November and 10th of December. And first thing is to have BLS training for laypersons, and it could be anywhere across the country, in any region, could be in schools like Naomi has done or anywhere, but it should be for laypersons. And we'd like you to do this through your member societies and anesthesiologists across the globe. And when you complete this training between the period of 10th November and 10th December, you have to send us 2 photographs and a short paragraph about the way the training was conducted, little details about it. And we will be, the president of the World Federation of Society of Anesthesiologists will be giving awards to not the one who conducts the maximum number of training sessions, but the most enthusiastic societies who's been very actively engaged in training laypersons. So that is the first thing. And the second one is a photography competition. And this is a contest any individual could participate in. And the topic is every citizen a lifesaver. So we want you to send 1 photograph. You could send more than 1 photograph. And that is the theme. It could be a black and white photograph with at least a minimum of 300 DPI. And it should be a good resolution picture, not too, not overexposed or underexposed. And, details of all this will go to the member societies shortly. So we really look forward to very, very active participation from all our member societies. And all this is being done in support of World Restart the Heart. Professor Böttiger is a very active part of this initiative, and that's the reason we chose this topic. And let's all take this together and work together to restart the heart. So I'll end by asking each of the speakers, to give a short message to our viewers, very, very brief message. I'll start with you, Prof. Böttiger.
Well, I would like to cite, thank you very much. I would like to cite the Indian Resuscitation Council. Let us make every citizen of the world a lifesaver, and therefore it's needed that they are educated in schools, because cardiac arrest is the 3rd leading cause of death in our world, and you cannot wait for the ambulance. If you start early, you can triple the surviving rates. And the fascinating thing with cardiac arrest is if you're doing CPR as early as possible, all people can survive in good conditions and probably not even need hypothermia.
Right. Rakesh?
Yeah, thank you so much. I think very good number of messages, informative key messages coming up. I would say that the outcome of a CPR is also based on a good team approach, but simultaneously formulation of guidelines, dissemination, creating awareness is also a team approach. And it needs to be all inclusiveness of all the stakeholders so that we can have good, robust guidelines and its dissemination so that we actually get the benefit out of it. And over and above, a good inclusiveness of researchers, trainers, and registry is an important aspect when we want to say improve outcome of our cardiac arrested victims.
Right. Over to you, Naomi. What's your message for the viewers?
The emphasis should be prevention of cardiac arrest and also BLS education since primary school for early identification of the emergency situations in the early CPR. Thank you.
Yes. So thank you very much. We can go on discussing, but in the interest of time, we have to wind up the webinar. I'd really like to thank the viewers for being here and our 3 speakers, Bernd, Rakesh, and Naomi, for their excellent informative presentation, really engaging speakers, and the World Federation of Society of Anesthesiologists for giving us the opportunity to conduct this webinar, and the Intensive and Critical Care Medicine Committee, which has started this initiative. And last but not the least, my 2 colleagues from the ICCM committee, Seda and Suneerat, for helping me moderate this session. So thank you, all of you, and all the best. Bye.
Thank you very much. All the best. Enjoy all around the world.
Bye.